Good morning. My name is Erin Moran, and I am the Clinic Partnership Manager here at the MAVEN Project. Thank you for joining us all today, and thank you to our friends at Cherokee Health Systems for hosting today's session on immigrant health and infectious disease with Dr. Mimi Cameron.
Hi. I'm not a big Zoom user. I'm Teams, so let me just get rid of this screen. Hi. I'm going to talk about immigrant health with a focus on infection and immunization today. And I have more material than we can actually go over. So some of it is for your information to look at later. Okay. Why did it not let me move forward? It's not letting me move forward for some reason.
Let's see.
Let me stop sharing for a minute. Sorry.
No worries. I also have them ready to go if you want me
I think
to.
if you could pull them up and I'll just have you move them because for some reason it's not letting him move me now. While Erin is pulling it up, I have nothing to disclose, and she's already mentioned the CME information. So we can go to the, keep going. So we can skip the disclosure, skip the CME. So our learning objectives today are to understand the difference between refugees, immigrants, and migrants, know how to screen for common ST sexually transmitted infections, know and use the basic treatments for these infections, know which adults to immunize and which vaccines to use, and know when to refer for specialty care. Next. Just a little definition. There's more than 280 million persons who lived outside their country of birth in 2022. A refugee is a person who, owing to a fear of being persecuted for many different reasons, is outside of the country of his or her nationality and is unable to return. An asylum seeker is someone who has submitted a claim to a government for refugee status and is waiting for the claim to be accepted or rejected. Asylum seekers seek to establish their refugee status after fleeing a country from where they hope to be granted asylum to a country. An asylee is a person whose claim has been granted, and a parolee is someone who's allowed to be in a country for urgent humanitarian reasons, but they're not a potential asylum seeker at that time. So, for example, people from Venezuela in this country right now may be parolees. An immigrant is someone who moves to a new country with the purpose of permanently moving there. And a migrant worker is someone who moves from place to place. And it matters what the definition is because the CDC and different agencies have made different recommendations in relationship to evaluation and vaccination. Next. So pre-screening happens with people who come through official processes, but people who come through non-traditional routes, including undocumented persons, people who came with the Afghan evacuation, or people who have already been long-term in the USA may not have been pre-screened, though sometimes they have copies of their medical records. Refugees, immigrants, and migrants who come through an official process are screened before arrival. They're screened for STIs, tuberculosis, illicit drug use, and psychiatric illness. Non-refugee immigrants are required to have vaccinations, but refugees are exempt. And refugees from tropical endemic areas are presumptively treated for other infections such as malaria and soil helminths. Next. So initial screening, the most important thing, and you know this already because you're a primary care clinic, is establish rapport. And what I mean by that is people who come particularly from non-traditional routes they have a lot of trauma. They may have PTSD. They may have suffered rape or torture. So establishing rapport is the most important thing. So what's at the bottom of this slide is the other important thing, is that not everything needs to be addressed in the initial visit. But there are certain things you should try to address, like a history and physical. If you have time, which if you're like most clinics, you probably don't, you do want to assess nutritional and growth assessment. You want to assess the social history, as I've already mentioned. The language that's spoken is important. Having the ability to do your evaluation through appropriate translation is important. Evaluating people's living situation. Do they have secure housing? Do they have secure food sources? And then when you actually get into the medical history, the top two things to look at are undiagnosed hypertension and diabetes. You also want to evaluate for pregnancy. You review immunization records that are available. Lower down on the list is dental health, but higher up on the list is a mental health evaluation. The basic laboratory studies that are suggested for your initial evaluation are CBC, a urinalysis, and a serum chemistry, including glucose. Next. So there are some physical exam hints. There's things you might not normally think about. You can look for signs of trauma on the skin, cigarette burns, scars, signs of infection such as leishmaniasis or leprosy. Leprosy can show up many years later. I saw a patient maybe about 8 years ago. He was sent to me for osteomyelitis of his finger. And I looked at his fingers. I said, they look a little odd. I pulled up his shirt and I saw some plaques on his torso. And so I diagnosed leprosy. For GI, you want to specifically look for hepatosplenomegaly, which could suggest malaria or schistosomiasis. Chagas disease, there are many people in this country that have latent Chagas disease. And if you diagnose it late in disease, then it would be suggested by cardiomegaly, possibly a heart murmur. And then for genital exam, you would also want to look for female cutting or a hydrocele. Someone asked where leprosy is endemic. I would say, so Southeast Asia, Africa, those are the big areas. The patient I mentioned was from the Philippines. Also India. Okay, next. Immunization. Most people do not have their records, particularly if they come across the border in a non-traditional way. But you review what they have. And if a vaccine was given, say an MMR, but at the wrong time, then it's invalid. Then the question is, do you test or do you not test, or do you just give them a vaccine? So I'm going to talk a little bit about measles further. I don't actually plan to talk a lot about MMR, but one approach is, if they don't remember, is just to give it, because we now have a measles outbreak, which I'm going to talk about. Hepatitis B testing is important before you immunize. Next. So hepatitis, why do we care about hepatitis? We don't usually screen for hepatitis A. If you did, a lot of people from developing countries have had hepatitis A. Screening for hepatitis B is very important, particularly in pregnant women. If there is evidence of active hepatitis B, then there should be further evaluation. I don't know if you have access to infectious diseases or GI, but they can be very helpful in helping you treat someone who has active hepatitis B. If someone is not infected and not immune, then you should vaccinate them. I'm going to talk a little bit more about the screening. I saw someone had a question. All adults over age 18 should be screened at least once for hepatitis C. And if they have risk factors, such as drug use or tattoos, they should have repeat screening. There's higher rates of hepatitis C in refugees from Pakistan, Egypt, Hmong from Thailand or Myanmar, or people from Somalia. If the initial screen is positive, a confirmatory test is required, though I've read that there's some newer tests being developed. If someone has detectable RNA for hepatitis C, then they should be referred for treatment. One thing I don't have in my slides is people with chronic hepatitis B and chronic hepatitis C should not drink alcohol. I'm sure you know that. They're also at higher risk for hepatocellular cancer, so they should be screened for that periodically with a ultrasound of the liver, particularly if they have cirrhosis. But that's where a specialist could give you some telephone advice. Next. So here, someone I think had asked about the testing. So when you screen for hepatitis B, you usually do a panel, and this just gives you a look at what kind of tests, what a panel may show you. So if someone had hepatitis B surface antigen negative, core antibody negative, surface antibody negative, then they have not had hepatitis B and they are susceptible. If they are core antibody positive or surface antibody positive, then they've had prior infection. If they're just surface antibody positive, they're immune to hepatitis B because they had vaccination. If they're surface antigen positive, then they are infected. And then if you look down the list, you can see whether it's acute infection or chronic infection. And what's more confusing is when you see someone with just core antibody positive. So they could be recovering from acute hepatitis B. They could have had prior infection and they might not have cleared it, or they might be susceptible with a false positive, or they might have undetectable antigen and be chronically infected. So those are someone you might follow a little further. Next. So this just, this color scheme just shows you what it means for the next slide. The yellow is vaccination for adults who meet age requirements. Blue is for shared decision-making. Purple is for adults with additional risk factors, and gray is no recommendation. So the next is the up-to-date. Next slide, please, Erin. This is the recommended immunization schedule, and I didn't really want to go over it in detail, but it's important that, as I've already mentioned, hepatitis B vaccine and MMR are important. And then you also want to look at varicella, tetanus, and also pneumococcal vaccines. There's some newer pneumococcal vaccines. So the CDC is the best place to go look at the detail on vaccination. And I put a link in the references. COVID vaccination, there's a new COVID vaccine that's coming out in the fall. I just saw an article about it today. This is not really respiratory virus season right now. So starting around August, September is when you want to start thinking about your respiratory virus vaccinations. But the others you can be giving at any time. Next. Meningococcal vaccine is for people at high risk. It's given to college students. It's also given to men having sex with men. It should be given to people with splenectomies or other immunocompromised states. Same with Haemophilus B, and Mpox vaccine should be used both prophylactically and after exposure if someone has not developed infection. Next. This is just a infographic for adults with other medical conditions. And I've already mentioned about meningococcal vaccine and HIB. I just want to mention respiratory syncytial virus is recommended for people who are older and people who are immunosuppressed. Next. So measles. Sorry, I want to check the time because I want to make sure we get to the important point. So measles is a highly infectious virus causing an acute febrile rash illness. I don't know if anyone in your clinic has seen measles. Not many people have. Important thing about it is there's a greater than a 90% secondary attack rate. And endemic measles was eliminated in the United States in 2000, but there's been outbreaks since 2019. And prior to the last couple of years, most of those outbreaks were due to imported cases in groups that traditionally did not get vaccinated. So in Orthodox Jewish communities and in Mennonite groups. But particularly since 2022, we've seen more outbreaks because of immigrants and refugees and migrants. And so there has been an outbreak I'm going to talk about in a minute, but I wanted to talk about the symptoms first. Symptoms start 7 to 14 days after exposure. Typically, it starts as a typical febrile illness, fever, cough, runny nose with conjunctivitis. 2 to 3 days later, if you're looking for them, you can find Koplik spots, which are white spots in oropharynx. I have a picture of that in a minute. 3 to 5 days later, the rash develops. It starts at the hairline and it spreads down to the face, to the trunk and the extremities, and then it can become raised. Next. So there are complications. You can have ear infection, diarrhea. Hospitalization occurs in 1 in 5 people who are unvaccinated. Pneumonia occurs in 1 in 20 children. Encephalitis occurs in 1 in 1,000 children. Death in 1 to 3 of every 1,000 children. If someone gets measles during pregnancy, there can be prematurity and low birth weight. And a more serious long-term complication is called subacute sclerosing panencephalitis. It's uncommon, can occur in up to 10 per 100,000 persons with measles, but the highest risk is in the under 2 years old, and it's a long-term neurologic disease. Next. So in 2024, between January and May 30th, there's already been 146 cases. Forgot to put in the percent that was outbreak associated, but most of it was outbreak associated. And if you look at the age range, you see that most was in the under 5 years old, 45%, but also a significant amount, 33%, was in the 20 plus years old, including adults in their 60s. The hospitalization rate was quite high. It was 55%. Nobody has died. That's the good thing. But the vaccination status was very interesting. Unvaccinated or unknown in 83%. 2 of the patients had 12% had had 2 doses of MMR and 5% had had 1 dose of MMR. Most of these cases were in, like I said, a refugee and immigrant population, and they were imported, but there were secondary cases in households because people were living in close proximity. Next. So this is a picture of a facial rash, and you can see it's somewhat confluent, But if you looked at this, and this is obviously a young child, it could look like other viral rashes that you see in young children. Next. So here is a rash in someone who has a darker skin tone, and you can see it's raised and it looks more like sandpaper if you look at the forehead. So it could be very subtle. Next. And this is hard to see, but those red spots, so if you look on the left, you see a red spot with a white topping to it. That's a Koplik spot, and that's inside the lips. Next. Okay, so a big issue is to look at sexually transmitted infections, STIs. As I mentioned early on, people suffer abuse sometimes in their transiting to our country, and so it's important to screen people. And not everyone has signs and symptoms. There's an increase in gonorrhea in the United States, which is drug resistant. There's been a significant increase in syphilis and congenital syphilis in the last 2 to 3 years. So it's important to screen for all of the common STIs. So gonorrhea, you can use a urine nucleic acid amplification test. More sensitive is a urethral or pharyngeal test. The pharyngeal test is not as sensitive, but it's an important test in people who have oral sex. So if someone has been sexually assaulted, you should definitely test them. If you have a positive leukocyte esterase on a urinalysis and you don't have a positive urine culture and they have no symptoms of urinary tract infection, you should test. Chlamydia also uses a urine nucleic acid amplification test, and you can also test on the urethra and the pharynx. Chlamydia is the most common sexually transmitted disease in the United States at this time. And it's more common in people who are sexually active, multiple partners. Again, if you see a positive leukocyte esterase or there's sexual trauma. Syphilis, everyone should be screened. If there's no documentation, check an RPR or VDRL. You want to confirm the positive test with a treponemal test. If there's neurologic symptoms, you need to consider doing a lumbar puncture to rule out neurosyphilis. And the reason for that is because the treatment is different. I don't know what Dr. Nguyen is asking on the chat. I can't see that. Can you see what the question was?
She has her hand raised. Would you like me to unmute her?
Yes.
Thank you. I was asking if patients come and they said they had vaccinations in the previous month or year, but they have no records. So what vaccines are safe for us to re-administer if we know that may be duplicate?
The only one that you probably would not want to administer is a pneumococcal vaccine. You'd want to wait at least a month. But anything else should be safe if you over-vaccinated. But, you could give Tdap, MMR, maybe not varicella, hepatitis B. I don't see a problem with any of them. Okay. Okay, next. Sorry, don't change yet. I'm not done with the slide, but someone had a question about penicillin. What was that? Someone, Erin, can you come back on, please, and mute Dr. Nguyen?
Yes.
Okay, someone had a question about penicillin, I think related to syphilis. I'm going to talk about the treatment, so maybe we can hold on that. So syphilis, like I said, if there's no if there's neurologic symptoms, you need to rule out neurosyphilis. HIV testing is no longer done in pre-screening since January of 2010. So it's suggested for all new refugees and immigrants and repeated in 3 to 6 months, and provide appropriate support and culturally competent care, preferably in their native language. I can't tell you how many patients I had come to me when I was at Kaiser who had been in this country 2 years, maybe 3 years, and said they had negative HIV in their home country, and then they were found to have HIV here, and they had actually AIDS, which suggested to me that they'd had HIV for much longer. I think what I'm gonna do is try to skip through some things so we can go through the chat questions at the end, if that's okay, because there seem to be a lot. Next slide, please. So gonorrhea has lots of different manifestations: urethritis, cervicitis, proctitis, epididymitis, pharyngitis, et cetera, et cetera, et cetera. I've mentioned there's increasing resistance to cephalosporins. There's also increasing resistance to azithromycin, particularly in men having sex with men. There's resistance to tetracycline. So the current recommended treatment, the bottom line, is ceftriaxone, IM, a gram if they're over 150 kilograms in weight, but otherwise 500 milligrams. And dual therapy, which used to be recommended, is not recommended. You want to test for cure about 7 to 14 days after treatment is completed, particularly for pharyngeal infections. The problem is that the antigen test can remain positive for longer, and we don't really do culture very much anymore. So that's the problem with this recommendation. Next. So chlamydia has similar presentations, but most often is asymptomatic. The treatment that's preferred is doxycycline 100 milligrams BID for 7 days. Just remember that it causes people to be sun sensitive, and it can sometimes cause GI upset. Azithromycin, a gram, can be given if patient is pregnant or if you're worried about non-compliance, but you should observe it. And it definitely causes gastrointestinal upset. You want to retest at 3 months, and the reinfection rate in women is 0 to 32%, and in men 15%. And you want to test for cure if they're pregnant or non-compliant, but don't test before 4 weeks. Next. Next slide, please. Erin? Erin, are you able to do the next slide?
Is the other STD issues the slide you'd like right now?
Yes. Yeah, so there's co-pathogens. It's not infrequent to see gonorrhea and chlamydia together. You can also see Mycoplasma genitalium. Someone asked me about addressing vaccination for HSV. I don't have any information to talk about that right now. For HIV, I've already mentioned to screen all patients, and they would need to be referred unless you have someone who's experienced in treating them. Next. Syphilis, I'm going to skip this, except to say that 46% of men having sex with men with syphilis are co-infected with HIV. So if you find syphilis, check for an HIV. This would be in the rest of your population too. And 80% of the cases are in men. It's associated with men having sex with men and methamphetamine use. Next. So just a little vignette about syphilis. One of my patients told me he went to a sex party. I asked him what that was. It was where you go to a building and there's random dark rooms. You go in the room and you have sex with someone you don't actually see, and then you go to the next room. And of course, he had syphilis. So it happens. And important thing is not to be not to make judgments about what people are doing, but just help them deal with the consequences of what they're doing. Syphilis, I don't think I have ever seen primary syphilis where you have a chancre. And maybe in your primary care clinic you do, but I don't think I have ever seen it. Maybe Dr. Nguyen has. You're more likely to see secondary, which develops weeks to months later. I'm just checking the time. And you typically see a rash, and it's usually red, but sometimes it's more of a brownish red. Sometimes you can have alopecia. You can have hepatitis, and I have seen people with hepatitis with syphilis. You can have synovitis or osteitis. Have not seen that, but you can also have renal disease. A tertiary syphilis is very uncommon in this country. I only saw it once. It was when I was a fellow. It was a long time ago. And it was a pretty young patient, my recollection. And he did have gummas and he had cardiovascular disease. He had aortitis. And with tertiary syphilis, you're more likely to have neuropsych complications. But neurosyphilis can occur at any stage. So again, it's uncommon because we're doing a better job of screening. So prevention, no, that's fine. Wait, did you skip a slide? Treatment. So the treatment, penicillin is the preferred drug, and it's the only drug to be used in pregnant women. And you use benzathine penicillin for primary or secondary syphilis, a single dose of 2.4 million units. If you find that there's a failure of response, you want to follow the non-treponemal tests such as the RPR. And if it doesn't go down by 4-fold at 12 months, it may be a failure of treatment, though 10 to 20% may not achieve that level of improvement. And if they do not, they need a neurologic assessment and reevaluation for HIV. Someone had said in the chat, what are the neuropsych complications of syphilis? Well, there's tabes dorsalis, where you have a wide base gait. You can have an Argyll-Robinson pupil if you're a member. You accommodate, but you don't react. You can have psychiatric illness. I mean, any neuro or psychiatric complication you can think of, you could have with syphilis. For latent syphilis, you also use benzathine penicillin. If you think it's early, so within the last year, you give a single dose. If you think it's late, then you would give a dose every week for 3 weeks. And that's what's preferred for those who have HIV or of unknown duration. Latent syphilis can be transmitted to the fetus. In tertiary syphilis, you can use the same treatment, but if they have neuro or ocular or otic syphilis, which are all neurologic forms of syphilis, then it's better to give IV penicillin. If someone is severely penicillin allergic and you cannot desensitize them because desensitization is unsuccessful, then you can use ceftriaxone, but it's considered a less optimum therapy. So it's better to try to desensitize someone to penicillin if you can. Next. So prevention is counseling about transmission. Safe sex is what you're counseling about. Using condoms, fewer partners, less random sex, not using drugs with sex, avoiding sexual activity until you complete treatment. Partner notification is very difficult. Sometimes it involves the health department, depending on your jurisdiction. If someone came to me with new HIV, let's say you diagnose that in one of your patients, I always offer them to bring their partner with them to talk about it, or to set up a telephone call to talk about it. It's very important to provide that support for your patients. Partners should be treated who have, if you diagnose gonorrhea, chlamydia, syphilis, or HIV. For HIV, of course, you should bring them in, but you can provide the treatment without testing the partner or send them to your local health department. Next. Sorry, I'm looking at the time here. I want to leave time for questions. Monkeypox. So monkeypox is an orthopox virus. It originally was found in the Congo Basin. There's 2 different clades. There was an outbreak in Nigeria in 2017 to 2018. A smallpox vaccination partially protects against monkeypox. It's now called Mpox. And there have been sporadic cases in West and Central Africa since smallpox vaccination has no longer been done since 1980. But then we come to the next slide and 2022. Next slide, Erin. I'm going to skip this. Skip that. So there was an outbreak worldwide in 2022. It was non-travel related. It was initially reported in the United Kingdom, then Portugal, Spain, and the United States. There was an international pride event in Spain, which led to transmission across Europe. And genome sequencing showed it was related to the Nigerian outbreak. In the US, there were more than 30,000 cases and 42 deaths, and it peaked in 2022. Worldwide, there were more than 87,000 cases. So Mpox is a virus. Most of it in the past occurred in people who lived in the forest in Africa, but the epidemiology has changed. In the outbreak, 98% of the cases were in men who had sex with men. And I've already talked about high-risk sexual activity. That's a risk. 40% of them were on HIV prophylaxis. So they were thinking about preventing HIV, but didn't have an understanding of monkeypox, Mpox. But in the US, 2.7% were cisgender women, and that was also mainly transmitted by sexual contact. In Spain, there was one report of transmission by tattoo. Next. HIV co-infection is important in people with Mpox, up to 42%. The other thing that's important is co-infection with other STIs. And as I had mentioned, the smallpox vaccine has some utility in prevention, but 18% of the people in Spain who got Mpox had been previously vaccinated, but many decades earlier. Most of you on this call maybe are too young to have had the smallpox vaccine. Next. Transmission, it's animal to human through body fluids or preparing bushmeat. It's also person-to-person, direct contact with body fluids, sores, and scabs. The most important thing about this is all phases of the rash are infectious, okay? So if you see a monkeypox, you're treating it, the patient is infectious until the rash is completely resolved. Even the scabs are infectious. So if someone comes into the clinic, you want to use contact isolation and droplet isolation and use a face shield. There's sexual transmission through the usual body fluids, and it can be transmitted through respiratory secretions, vertical, from mother to fetus, percutaneous injury. There's, I think, only 2 cases that I'm aware of. Someone in Brazil tried to unroof a lesion to send it for testing, and they stuck their finger after unroofing it. And indirectly with contact with fomites. Fomites are the objects in the environment. They're not the virus on the objects. Next. So a lot of community transmission due to direct intimate contact, but household contact was actually quite low, and the healthcare risk is low. Next. So the skin shedding can occur for 25 days, virus from the rectum 16 days, oral pharynx 16 days, and semen 13 days, blood only 1 day. But shedding can be variable. And someone can have a positive PCR but have inactive virus. I think the important point I want you to take home is that until the lesions heal, which take 2 to 4 weeks, but much longer in people who are immunosuppressed and not treated for HIV or immunosuppressed for other reasons, it can take longer. Next. The prodrome is fever, headache, myalgia is a typical viral illness. And then some people presented with the anogenital and oral lesions without a prodrome. You can have regional lymphadenopathy, and I've mentioned the rash. Next. Wherever you can get it, you can have a problem. So proctitis, pharyngitis, you can have ocular. People had cephalitis. There's complications, including bowel obstruction, myocarditis. Those are uncommon. I think I'm looking at the time, and I think I'm going to skip most of the rest of monkeypox. Go ahead. Next slide. This is just a picture. No, I do want them to see the pictures. Okay, so you can see how the rash varies. The initial rash is on the left upper picture, and you can see it starts to umbilicate if you look on the upper right, and then you see it becomes scab-like, and even the scabs are infectious. Next. So here's a more extensive rash on the face, on the left upper, and you see on the hands, on the right lower, and they're firmer to the touch. They're not very fragile, so they feel more rubbery. But of course, you're not going to be feeling them unless you're wearing gloves, and I recommend you don't feel them, and even if you're wearing gloves, because you don't want to contaminate yourself. Next. This is just an example on the penis, but you could see that if you saw this, you might look at it and it's an isolated lesion, it's an ulcer. You might say, is that herpes? Is that mpox? Is that syphilis? It's not as clear. They say it's a papule, but that looks more ulcerated to me. Next. Okay, the prognosis is good, except in people who are immunosuppressed. If someone has been exposed but does not currently have infection, you want to refer them for vaccination. If it's a household member, you definitely want to refer them for vaccination, even if they're not a sexual partner. Next. The risks for severe disease I've mentioned are immunocompromised or people with HIV with a CD4 count of less than 200, even if they were on appropriate antiretroviral therapy. Next. So there have been some cases in 2023 and 2024. There was an outbreak in Chicago. And the interesting thing about the outbreak in Chicago, it was 12 patients, is 69% of them had actually had 2 doses of the Hinios vaccine, which is the smallpox vaccine that was released by the federal government during the mpox outbreak. It's still occurring sporadically, and there is a major outbreak in Southern Democratic Republic of Congo right now in the Kivu region, and there's multiple modes of transmission. There's mining going on, so there's transmission going on among sex workers and truckers, but there's also transmission in adolescents who are out in the forest, probably being exposed through bushmeat. Next. I'm going to skip the differential diagnosis. It's all the things that could cause similar rashes. And the appearance of the lesion could suggest the diagnosis, and I've shown you pictures. I just want to briefly mention testing. Go to the next slide, I think is the testing. I don't know whether your health department does it locally or you can send it out, but these are instructions for collecting a sample. You need to have the right swab and transport material, and you do not want to unroof it. You do not want to use a needle. You want to be in full protective gear, and what you would do is you would apply firm pressure to the lesion so that you're sure that you can collect a sample. If it is a lesion that ruptures, then you would collect the fluid with the tip of your swab. And you want to avoid swabs that bend or break too easily. And you want to rub it 2 or 3 times and then put it in the container. Next. There's two, if you want to collect it from a crusted lesion, first you have to confirm that your lab would take a crusted lesion, and then you would use a forceps or a blunt tip sterile instrument to take a piece of the crust and put it in a dry container. Next. We are running out of time. We have 13 minutes, so I'm going to breeze through tuberculosis. But if you ever want to talk just about tuberculosis, I can do that. Why does it matter? 10 million people in the world have active tuberculosis in 2020. And it is one of the world's deadliest diseases. And in the United States in 2023, we saw an increase of tuberculosis. So go to the next slide. There's estimate of 13 million people with latent tuberculosis in the United States. 85% of active tuberculosis is attributed to reactivation in people with latent tuberculosis. So you're more likely to see latent tuberculosis in the clinic or in your population of immigrants, but that requires treatment to prevent reactivation. In 2023, there were almost 10,000 active tuberculosis cases in the United States, which was a rate of 2.9 cases per 100,000. Now, I didn't know that your clinic was in Tennessee, or I would have looked up your statistics. But at my hospital, which is a suburban hospital, we saw 16 cases of active tuberculosis last year. But in my county, which is in the richest county in Maryland, and one of the richest counties in the country, our rate was higher than the national rate. It was 4.9 per 100,000 people. So it's important to know your local epidemiology. 1 in 10 people with latent tuberculosis will reactivate. And what is the other thing I wanted to mention? I wanted to talk a little bit about resistance. In 2022, there were about 8.4% of people with tuberculosis had resistance to INH. That's called primary resistance. Multi-drug resistance is people who are resistant to isoniazid and rifampin, and that was low, 1.5%. But there's also what's called pre-extensively resistant tuberculosis, which is resistance to the INH and rifampin plus a quinolone or an injectable drug, and that occurred in 16 people in 2022. The CDC is always a year or 2 years behind on their statistics on tuberculosis. And extensively drug-resistant tuberculosis, which is resistance to INH, rifampin, fluoroquinolone, and one of the injectable drugs, occurred in 5 cases. Next. I'm going to present a case, so we'll skip this. Go to the next one. This risk of TB is exposure to someone with active TB, foreign-born, Asian, Latin American, Caribbean, African, Eastern European, Russian. In our country, most of the people with TB come from Mexico, Philippines, India, Vietnam, China, live in high-risk settings such as correctional institutions, long-term care facilities, homeless shelters, healthcare workers, infants and children and adolescents exposed to adults with TB or latent TB, and then immunosuppression. And there is a difference in race based on people's racial background, and Native Hawaiians and Pacific Islanders have the highest rate. Next. Diabetes is an important risk factor. Alcohol is a risk factor. HIV is a risk factor. Non-injectable drug use and injectable drug use, homelessness, and I've already mentioned the other two. Next. Skip this slide. I'm just going to present this case. So this was a patient we had at Kaiser. He was a Bolivian immigrant. He had a sore throat and odynophagia. He was seen in urgent care. He had some dysphonia and dry cough, and he had a lump on the right side of his neck. He had a 10-pound weight loss, and he had some type of gastric surgery due to a congenital condition. He had laryngoscopy done, and they saw a fibrinous exudate and a mucosal change. They gave him augmentin and steroids. He also had a barium swallow, which showed he had reflux in his Encke's diverticulum. He was given PPI, and he briefly improved. Next. So he underwent a biopsy of his larynx, and it showed AFB. So the two most infectious forms of tuberculosis are pulmonary, that's cavitary, and laryngeal TB, because people are coughing out many bacterium. It only takes one TB tubercle to infect someone. But that being said, even if you were taking care of a patient and you did not know they had tuberculosis and you did not wear an N95 mask, the risk of you developing active TB as a healthcare worker is still relatively low. Latent TB, yes, but active TB, no. So skip the rest of this case. Okay, so sorry, I did like a quick thing through TB. I just want to mention a couple things that I didn't review on one of the slides. So latent TB is most common, but active TB is most likely to be pulmonary, but you can also see laryngeal TB is uncommon. Gastrointestinal TB is not common, but it does occur in this country. Genitourinary TB does occur. Miliary TB is also present, but the one you may see is a scrofula, which is lymph nodal TB, particularly in the neck. I've seen a lot of that, actually. And if you saw someone with that, the diagnosis is usually made by a lymph node biopsy. But if you're thinking TB, you also want to do a chest X-ray, and you want to screen with a skin test or a quantiferon, depending on what you have access to. It's important to know that someone with active TB could have a negative skin test or a negative IGRA, either a quantiferon or a T-spot. And I didn't really talk about them because we don't have time. The last thing to think about are soil helminths. Pre-immigration treatment, I mentioned, should have occurred if they came into the country by a authorized route, and they would get albendazole and ivermectin unless they were pregnant, except immigrants who come from Africa have to be ruled out for LOA before ivermectin is given. And African immigrants without LOA should have also been given praziquantel. So these are the questions you would want to ask someone if they came in particular from Africa. And screening is recommended for soil helminths in people who were not pre-treated from Africa, Latin America, Caribbean, Asia, Middle East, and particularly within 6 months of arrival. And I think that might almost be my last slide. Can you go next? No, sorry. Yes, there's strongyloides, schistosomiasis, loa. That's all I'm going to say. Next. And then malaria, you should think about malaria if they weren't treated or pre-screened. A subclinical Plasmodium falciparum is rare, and I put the treatment there. Next. I don't think we have time to talk about Chagas disease because I want to do what the questions are in the chat. So there's information here you can look at for that. Okay, let's see. Other infections that can occur, filariasis, onchocerciasis, giardia is common in this country, amoebiasis, tapeworm infections. Neurocysticercosis is the most common cause of seizures in people from Latin America. There's chronic bacterial infections, there's fungal infections, and then human T-cell leukemia type 1. Let me see if I can look at the chat questions. I think this was my last slide other than references. Okay, have I seen TB cases with osteo involvement? Osteo-TB, I have seen Pott's disease. It's not common, but it does occur. Yes, you can see osteomyelitis with TB at the health department. They had a patient with toe TB once. So BCG testing, first of all, someone asked about, can I mention the approach for people who've had documented BCG in regard to TB testing? I didn't really talk about TB testing because it's a talk in itself, but if someone has had BCG, it's usually decades before you're testing them, but sometimes not. Sometimes they get a dose just before they leave their country. And if they have a positive skin test or a positive quantiferon, they have latent TB. Okay, so positive test, latent TB at the minimum if they have no symptoms of active TB. So you can test people with BCG. Some of them are afraid to be tested. So if you have access to an IGRA test, either a T-spot or a quantiferon, you can do that and they won't have a skin reaction. So is respiratory TB more infectious than other types? Someone asked that question. The answer is yes. But laryngeal is probably even more infectious if someone is coughing. Someone asked for subtle symptoms of neurosyphilis. So psychosis could be a subtle sign of neurosyphilis. Burning sensations could be a more subtle sign of syphilis before you get tabes dorsalis. Memory loss could be a subtle sign of syphilis. And I'm sorry, I don't have any information about HSV vaccination. Can I assume adults from other countries born before 1980 are immune to chickenpox, or i.e. no need to immunize? I would not make that assumption. I would have to look it up. I mean, I don't have that kind of knowledge memorized, and I would want to look it up. Okay, Dr. Nguyen already asked about if vaccination records are not available and stated what they had. If I don't see them, I don't believe it. Seeing is believing. If someone said they had a penicillin injection and there was no record for syphilis, it usually means it was done at the health department. And if you call the health department, they can give it to you, the information. But if they have no record, I wouldn't assume for a syphilis in particular that they'd had an injection. See, someone already asked about HIV screening. I've already mentioned that. And I talked about hepatitis B screening. And I mentioned some of the countries which have leprosy. We're at time. Are there any other questions? Anyone have their hand raised? That was a lot of information in a very short amount of time. If there's any of the topics that you want in more detail, we already have some of the topics with longer detail at MAVEN, or if there's any that I talked about that I didn't really get to that you want to have a later CME about, just reach out to MAVEN and I can prepare a talk if that would be helpful.
Thank you so much, Dr. Cameron, for your time today.
And thank you for inviting me. And just so you know, I had to teach myself about immigrant health too. So I always like to learn new things.
All right, well, thank you so much. I hope everybody has a great afternoon. Oh, and you're getting lots of good comments in the chat here.
Well, I appreciate that.
Yeah, likewise.
Okay.
Well, I apologize for the internet issue I had, but thank you
No,
for your
that's
patience.
okay, because I must have had it too, because I couldn't advance my slides. No
No worries.
problem. It
You got
worked
it
out.
done.
Thank you, Erin. It was nice to meet you and look forward to working with you again.
Yeah, likewise. Have a great afternoon.